Today, I'm going to talk about anesthesia care. It's one of the part of an enhanced recovery program. I have no disclosure. And I'm pretty sure you've seen several times these slides. And with this slide, I would really point out that many of the enhanced recovery after surgery elements are under control of anesthesiologists. So as an anesthesiologist, we take an important role in facilitating surgical recovery. Yesterday we talked about preoperative optimization. Intraoperatively, we control fluid management, ventilation, analgesia, depth of anesthesia. Postoperative, we are in charge of pain management. And most of our analgesia techniques aim not only to reduce pain, but also to facilitate early feeding and early mobilization. So we must be aware about the importance, our importance in facilitating surgical recovery. And with these slides, the animation didn't come out. But basically, in this graph here, you can see that from 2003 to 2010, on the y-axis here are the number of publications that came out about enhanced recovery after surgery programs. And there's an exponential growth in publication up to 2010. However, under these slides here, this box here, guess how many publications were published in anesthesia journals? Out of this number is 55. Guess. 3. So this means that despite we control many of the enhanced recovery after surgery elements, and we don't read surgical journals, we are not really familiar and aware about this problem. So as a community, as an anesthesiologist community, we should be more involved in research and acknowledging our importance in accelerating surgical recovery. So why is it important? We talked a little bit yesterday about controlling surgical stress. And when we talk about surgical stress, stress is induced by inflammatory response associated with surgery, pain, and also the metabolic changes occurring. And all these elements interact each other. And the surgical stress is represented by the development of insulin resistance that is caused by release of catabolic hormones such as cortisol, glucagon, and catecholamines that increase plasma glucose level, increase proteolysis to create acute phase proteins, and also they increase glycolysis and glycogenolysis. The result is less glucose for cells to properly work. And we discussed about, does it always happen with surgery? Yes, insulin resistance happen all the time. And even with the 24-hour bed rest or a period of fasting, insulin resistance occurs. We have a reduction by 20% of insulin sensitivity. And with the degree of the surgical insult, higher is the surgical insult, greater is the insulin resistance that develops. So yes, insulin resistance occurs all the time. And why is important insulin resistance? Because insulin resistance is associated with delayed impaired recovery, increased protein catabolism, muscle weakness, increased postoperative complications, and also has been shown to be a significant predictor of prolonged hospital stay. So which are the weapons we have to control surgical stress? Many. And as anesthesiologists, we can use them in the perioperative period. We can use regional technique, neuroaxial blockade, spinal or epidural or peripheral nerve block. We can use pharmacologic intervention, talk a little bit about beta blockers, statins, control of pain, and also we control fluid management and temperature control that also are associated, are important triggers for the surgical stress. I would like to start talk about a little bit of premedication is one of the enhanced recovery after surgery elements, and despite we talk a lot about avoiding long-acting medication, and although it seems intuitive that if I give something that delays patient's awakening or make the patient dizzy and drowsy after surgery, delay recovery, there's not very strong evidence, and in larger randomized control trials showing that avoiding long-acting premedication in the context of an enhanced recovery program facilitate early recovery. However, we try to avoid long-acting opioids such as morphine, are associated with several side effects that impair recovery, or long-acting benzodiazepine. And even short-acting benzodiazepine in elderly people are associated with increased risk of postoperative delirium and cognitive dysfunction. So what we do in our institution, we use some midazolam or fentanyl when we have to do some invasive procedures before the surgery in people younger than 65 years old, and we tried either to avoid premedication in patients who are older, or we give like small dose of propofol during the procedure. One of the most important premedications we have is patient information. Knowing what's going to happen exactly before the surgery helps patient understanding and reduce anxiety levels, and also help to cooperate with you during your procedure. So in the booklet that we talked a little bit yesterday about patient information, it's important also that you explain what is an epidural, what's in a spinal, whatever you are planning to do has to be specified and illustrated maybe with pictures, so patients come to the theater already knowing what's going on. Again, in terms of anesthetic choice, there's a lot of research to do. We don't know which is the best anesthetic, inhalation or intravenous for patients undergoing surgery within an enhanced recovery programs. Early studies were done by Dr. Kellett, were done with total intravenous anesthesia. Most of the study published they do not mention about the anesthetic choice, or they just randomly use inhalation agents or intravenous agents. Which is the best? I don't know. More research to do. Avoid nitrous oxide, increase the risk of nausea and vomiting, and especially if you're performing laparoscopic procedures. 80% of our procedures are done laparoscopically, so we stop using nitrous oxide. And there's a recent evidence suggesting that too deep anesthesia can impair recovery. And so how do we know that our anesthetic depth is too deep or is too light? There are several anesthetic monitoring that we can use. Definitely the most studied used into clinical practice is the BIS monitor. And despite was introduced as a tool to prevent awareness, its use failed to prevent awareness in the most of the randomized control trials that have been published, especially in a non-high-risk population. But you have to look at the BIS as a tool not really to prevent awareness, but a tool to reduce the amount of anesthetic that we give to our patients in order to facilitate recovery, reduce the hemodynamic effect of our anesthetic agent, and also try to reduce wakening time. In these recent large randomized control trials, authors randomized 902 patients in two groups. One group receiving anesthesia without a BIS monitor, and the other group titrating anesthesia depth, maintaining BIS between 40 and 60. There were no particular protocol in terms of type of anesthetics. They were using either intravenous anesthesia or inhalation anesthesia. And their primary outcome was impairment of cognitive function after surgery in terms of postoperative delirium in hospital and postoperative cognitive dysfunction at 1 week and 3 months. And the author found that patients who receive anesthesia-guided DBs had less postoperative delirium, and there was a trend in less postoperative cognitive dysfunction at 1 week, but was not significant, almost, and there was a significant reduction at postoperative cognitive dysfunction at 3 months in the group BIS-guided. Furthermore, the authors, they were able to show that using BIS reduce anesthetic consumption and opioid consumptions. Further studies come from the Cleveland group showing that, again, too deep anesthesia indicated by low BIS level associated with low blood pressure and low MAC, that is actually the opposite of low BIS, can significantly increase mortality and prolong length of stay. The meaning of these results are not really well understood. It seems that these results reflect mainly a very sick population undergoing surgery, where you really want to, they can't tolerate high degree or a high level of anesthesia, and therefore they show up with a low blood pressure and for some reason very reduced cerebral activity represented by low BIS values. So intraoperative, we have, again, a lot of intervention to attenuate stress, and when we talk about stress, we mention thermal stress, control of normothermia, nociceptive stress, metabolic stress, and inflammation. What can we use? We know that, for example, anti-inflammatories started either before the surgery or during the surgery. And there's some data on high dose of steroids, mainly coming from the orthopedic literature, that can reduce inflammation. Intravenous lidocaine is a very strong anti-inflammatory agent, easy, cheap to use. Neuroaxial anesthesia, either thoracic, epidural, or spinal, blunt the metabolic response associated with stress response induced by surgical stress. And if you don't want to use neuroaxial blockade, there are data showing that relatively high dose of intravenous remifentanil can reduce the metabolic response associated with surgery as well. If you want to use remifentanil, there are data showing that can be associated with, like all the other opioids, to opioid-induced hyperalgesia. So when we use remifentanil in our institution, trying to prevent this, we use either a small dose of ketamine or magnesium together with remifentanil. Hypothermia is common during anesthesia. Every time we put to sleep someone or we perform even a spinal anesthesia, hypothermia occurs. If we don't measure, we are not aware. So first message is you need to measure temperature during the surgery. And hypothermia has been associated with several outcomes: increased blood loss, increased cardiac events, allogenic blood transfusion, increased protein breakdown, prolong the effect of our anesthetic agents, neuromuscular agents, and increase hospital stay. Although these data come from an era where enhanced recovery programs were not really implemented yet. So we don't know the effect of hypothermia today, although it seems intuitive that hypothermic patients, they don't do so well compared to normothermic patient, even with an enhanced recovery program. We talk about adequate muscle relaxation. As I said, 80% of our procedures are done laparoscopically in our institution. This is a recent study showing that adequate level of muscle relaxation identified by a post-tetanic count of 1 to 2 compared to moderate neuromuscular blockade identified by training of 4 or 1 and 2 improves surgical conditions. They ask surgeons that were actually looking at surgery performed by other surgeons to score using these tools surgical conditions, and they also, after the surgery, they ask the surgeon to score surgical conditions in 2 different contexts of neuromuscular blockade, and patients who receive deeper neuromuscular blockade had better surgical condition in terms of intra-abdominal visualization and the need of neuromuscular blockade. So yes, it is important. However, we also know that too deep muscle relaxation can increase the risk of hypoxia and respiratory complication in the immediate postoperative period. So what do we have to do? Definitely we need to monitor neuromuscular activity. If we don't monitor, like for temperature, don't know where we are. Just looking at the ventilator or clinical signs of adequate muscle relaxation is not enough. We need to measure it. So where are we going to measure it? Usually we measure it, all the early study on muscle relaxation were performed at the adductor pollicis, and especially in patients undergoing laparoscopic surgery that they have both arms tucked in. This is not very practical to do. So they start using neuromuscular monitoring at the level of the eye muscles. And this is a nice study, was published 2 years ago, where they look at if there is a difference in monitoring neuromuscular blockade at the level of the adductor pollicis or the eye muscles. And the authors showed that if we measure neuromuscular function at the level of the adductor pollicis or the eye muscle, if we measure at the level of the eye muscle, the degree of residual paralysis is higher than at the level of the adductor pollicis. So it means that during the surgery, as eye muscle represent mainly diaphragm activity, is okay, monitor neuromuscular function here, neuromuscular function at the level of the eyes. However, in the awakening phase, you need to change your site of monitoring at the level of the adductor pollicis, because these represent the tone of muscle of the larynx and the upper airway that is associated with impaired respiratory function in the early postoperative period. So even the monitoring is important. In terms of PONV prophylaxis, plenty of data available. We need to identify patients at higher risk of postoperative nausea and vomiting. The most used score is the Apfel score, very easy to apply and remember. There's an exponential growth of risk of postoperative nausea and vomiting with the presence of one or more elements. So female, no smoker, history of postoperative nausea and vomiting, or postoperative opioids, almost 100% of our patients have it. They should be treated accordingly to the stratification of the risk. So if these are the recent guidelines updated, not much changes compared to 2002, I believe, guidelines. If the patient has only one risk factor of postoperative nausea and vomiting, you can use one of the antiemetic agent, either dexamethasone, droperidol, or ondansetron. More than two risk factors of postoperative nausea and vomiting, you need to use 2 prophylactic antiemetic agent. In the ERAS protocol, there's no mentioning about intraoperative ventilation, although in the last year, 2 large randomized controlled trials were published about the importance of intraoperative ventilatory strategies to improve postoperative outcomes. These data mainly come from ARDS patients, ICU patients, where we know that lung protective strategies can improve outcomes, but has been poorly studied during the intraoperative period. And we know that during anesthesia, respiratory function is significantly impaired by several factors. This is called a multiple hit model that was developed in ARDS patients. We know that as soon as we put to sleep the patients, FRC, functional residual capacity, is reduced. Retractor used by the surgeons or the insufflation of the pneumoperitoneum shift towards the mediastinum, the diaphragm, increasing atelectasis. Furthermore, hyperinsufflation of the alveoli or hypoinsufflation of the alveoli is associated with increase of cytokines at the level of the lungs, but also with cytokines as a marker of systemic inflammation, and that we know that impairs recovery. So what can we do to minimize all these things that are happening at the level of the lungs? In 2006 and 2008, this group published 2 papers, actually are the same, but they look at different outcomes on different protective ventilatory strategy using 6 ml per kilo of ideal body weight, PEEP 10 centimeter of water, and no recruitment maneuver, versus a standard ventilation with 12 ml per kilo of ideal body weight and no PEEP with a 0.4 FiO2. And they look at inflammatory marker at the level of the lungs and also systemic cytokines. And they were able to show that in the protective ventilation strategy group, these inflammatory markers were reduced. In 2012, a large randomized controlled trial looked at clinical outcomes and respiratory function. Respiratory function tests were their primary outcomes. And they were able not to show a difference between patients who were ventilated with the protective ventilatory strategy or with the standard ventilation strategy. However, if you look at the 2 different ventilation strategies, they use a lower amount of PEEP, and also they did not use recruitment maneuver, and the FiO2 was pretty much similar. This was one of the co-authors of the other large randomized controlled trial published in New England Journal of Medicine that show similar results. They had pretty much the same protective ventilatory strategy, so reduced tidal volume, higher PEEP, more than 5 centimeters of water, and what they add recruitment maneuvers, try to reopen the area of the lungs that were collapsed, stating that PEEP does not opening areas that are already collapsed. What it does, PEEP just maintain this area open. So if you want to try to recruit area of the lungs that are collapsed, you need to add regular recruitment maneuver. And what they look at clinical outcomes such as pulmonary and extrapulmonary complications, and they were able to significantly show a reduction of major pulmonary and extrapulmonary complication in patients receiving protective ventilatory lung strategies. Sorry. So what's the ideal oxygen concentration we need to use? Early studies showing that higher oxygen concentration might reduce surgical site infection or reduce the risk of postoperative nausea and vomiting. However, recent study and data coming from non-surgical populations, such as patients undergoing who are having a heart attack or angina, show that higher oxygen concentration can actually get worse outcome. So these are a national study, randomized controlled trials, the PROXI trials, comparing high oxygen fraction, 80% versus 30% in different Danish centers. And their primary outcome were surgical site infection, and they will also look at the effect of oxygen on atelectasis and 30-day mortality. They were not able to show a significant benefit of high oxygen concentration, as was shown in previous studies, on surgical site infection and atelectasis and as well mortality. What is interesting about this study is their follow-up study that the author published 2 years ago, 5 years after, and they looked at patients who receive higher oxygen concentrations, have higher risk, 30% chance higher to die compared to those that receive 30% of oxygen. And when they look at subgroup analysis, they were able to show this difference mainly in cancer patients, and the statistically significant results were lost in non-cancer patients. So the authors speculate that high oxygen concentration may have also an effect on cancer recurrence. Unfortunately, despite the study design was very well done and was well-powered to show a difference in their primary outcome, that was surgical site infection and atelectasis, the authors in this follow-up study, they don't tell us why this patient died. Do they die because they were hit by a bus? Do they die because of cancer? Do they die because of cardiovascular disease? So we can't really say that high oxygen concentration increased the risk of cancer recurrence. We talk about operative glucose control. It's a hot topic because we do not know which is the best target that we need to achieve intraoperatively. Definitely tight glycemic control, and the study were shown in ICU patients doesn't seem to be, the same results are not being reproduced in the surgical population. We know, though, that hyperglycemia is associated with complications. These are data coming from the NESQIP database, 7,000 patients looking at glucose level the day of surgery. And they showed that moderate or severe hyperglycemia was associated with increased risk of surgical site infection, pneumonia, and the reoperation rate. So, what to do? Definitely, again, we need to measure. If we don't measure, we are not aware where we are going. Measure glucose. Identify patients at a higher risk of hyperglycemia. Patients, yesterday we showed a study in non-diabetic patients coming to the theater with a higher level of hemoglobin A1C at a higher risk of hyperglycemia and postoperative complications. And we try to maintain glucose between 150 and 180 milligram per deciliter. Important is also try to reduce blood sugar variability that seems to be associated with impaired outcomes as well. And of course, avoid hypoglycemia. Fluid management, Dr. Collins is going to talk about this. I just would like to highlight that fluid requirements have been severely overestimated during years, and especially in the context of an enhanced recovery program where fasting time are reduced, mechanical bowel preparation are not used anymore. We give patients carbohydrate loading, and we use intraoperative goal-derived fluid therapy technique. The intravascular requirements are significantly reduced. Therefore, the amount of fluids that we need to administer to our case is significantly less than what we thought 10 years ago. How do we treat hypotension? The most common anesthesiology reflex to treat hypotension is to give fluids. There's a beautiful study done in patients receiving epidural. And what they did intraoperatively, they look at bowel perfusion with a Doppler at the level of the seriosa of the colon and the mesenteric artery. And you can see here they measure MAP, cardiac output, CVP, and bowel flow. See, when the patients loaded, the anesthetist loaded the epidural, cardiac perfusion and bowel perfusion reduced, as well as MAP. They gave fluids. CVP, of course, increased, but bowel perfusion did not increase. It was a mild increase in cardiac output. Only when we're able to give alpha-1 agonist, MAP and bowel perfusion increase. This is to say that we pharmacologically induce hypotension. And hypotension depends on what is the cause of hypotension. It has to be treated either with fluids or with pressors. Do not assume that Hypotension is always caused by hypovolemia. Make sure that your patient is normovolemic and use the adequate treatment to improve organ perfusion. In terms of pain control, briefly, intraoperative, we have different strategies. We already mentioned thoracic epidural analgesia. For open case, what we do, we always put a thoracic epidural analgesia, thoracic and not lumbar. There's no point of putting a lumbar epidural, increase the risk of urinary retention and motor blockade, and you lose all the physiologic effect on bowel function and cardiovascular and respiratory function as well. But you need to put a thoracic epidural, but you have to make sure that it works. There's no point to put epidurals that do not work. Increase just the risk for the patients and also increase cost and resources for the hospital. So my message is test epidural even with 4 or 5 cc of lidocaine before putting the patient to sleep. You are able to identify quickly if the epidural is in place or not. You should have aiming to a primary failure, so epidural that had never been placed in the epidural space, less than 8%. That's what comes from the literature. If epidurals is not indicated, you can always use intravenous lidocaine or spinal anesthesia with intrathecal morphine, and we have Dr. Fawcett is going to talk about this after. For laparoscopic procedures, again, you need to identify what is the type of surgery. Analgesia should be procedure specific. We can't think that one type of analgesia works for all type of surgery. What we do for right and left hemicolectomy, we avoid to put thoracic epidural. We use manual intravenous lidocaine or spinal. We sometimes put thoracic epidural, especially for high-risk patients, for pulmonary complications. For rectal procedures, where our surgeon perform a kind of fantasy-like incisions, we found that in the first 24 hours, in a study we published last year, epidural offers some benefits in terms of pain control compared to spinal or intravenous lidocaine. After 24 hours, the effect on pain control remains the same. But again, this has to be discussed with your surgeon. There are different ways to perform rectal procedures, intracorporeal anastomosis, extracorporeal anastomosis, where the incision is going to be done. So you have to know about the surgical technique as well. Just to finish my talk, and I would like just to think and share this with you. So when we talk about pain management, are we trying only to improve pain control or also to improve outcomes and reducing complications? This was published in an editorial about high epidurals in patients undergoing cardiac surgery 2 years ago. And in this editorial, the author stated that high thoracic epidural for patients undergoing cardiac surgery was not the evidence of reducing outcomes, improving outcome, reducing complication was not that strong. However, when we look at pain outcomes, there was a significant benefit of using this type of technique in this population. And this type of question has to be applied as well in the context of an enhanced recovery program. This study showed that, for example, epidural analgesia used with a general anesthetic was published recently last year, was a meta-analysis, was able to reduce by 40% mortality and reduce also cardiovascular and respiratory complication, and also facilitating the recovery of bowel function, with the downside of increasing the risk of urinary retention and hypotension. So it seems that, for example, for epidural, there is an effect on morbidity and mortality. But when we put our epidural technique in the context of an enhanced recovery program to improve outcomes, let's take an example, recovery of bowel function. These are all the other elements, enhanced recovery elements, that are associated with improvement of recovery of bowel function. And then we add our thoracic epidural analgesia. So how do we know that the effect of thoracic epidural analgesia on bowel function that is well established, further improve the recovery of bowel function in this context. Maybe the effect of thoracic epidural analgesia in this context is less obvious than earlier studies when all these elements were not used in the same care. So the effect of our analgesia technique may be blunted by improvement of quality of care in this context. And that's it. So avoid too deep anesthesia, avoid to use premedications, especially in the elderly. You need to measure temperature. You have to make sure that you have strategy to optimize fluid management. Dr. Collins is going to talk about that. Measure glucose. Use evidence-based and procedure-specific pain protocols. And do not assume that hypotension is always the result of hypovolemia unless it's proven. Thank you very much.